Now I request our next speaker, Dr. Iftekher.iqbal. He is going to present on neovascular glaucoma, mastering the challenge. Dr. Iqbal.
Is my slide visible? Yeah, okay. So greetings, everyone. I'm Dr. Iftekher.iqbal. Welcome all of you in my today's presentation. And I'm really grateful to BYOS for giving me this opportunity to present. And now I'm going to present about the neovascular glaucoma. So regarding the presentation, I don't have any financial interest to disclose. So if you look at the presentation overview, I'll go through some basics about the neovascular glaucoma. Then I'll discuss about 3 cases where I had to do the augmented trabeculectomy, glaucoma drainage device, and cyclophotocoagulation. And later, I'll discuss about the key learning points regarding this presentation. So first of all, as we all know, the glaucoma is a neurodegenerative disorders. And in case of primary, it can be either primary or secondary. So neovascular glaucoma is one of the sight-threatening secondary glaucoma, which is caused by the rubeosis iritis and raised intraocular pressure. Back in 1906, Court described the rubeosis iritis in a patient with central retinal vein occlusion, and later Weiss et al. Proposed the neovascular glaucoma term in 1963. Though the prevalence is very low in the literature, is around 0.01% in the Hooghly River study, but it is quite common in our day-to-day practice because of the high prevalence of diabetes mellitus. And as a secondary glaucoma, its proportion is around 9 to 17.4%. So what causes the neovascular glaucoma? It is the retinal ischemia or the hypoxia that plays the major role in the development of neovascularization. And whenever there is a retinal ischemia or the retinal hypoxia, that causes the imbalance between the angiogenic and the anti-angiogenic factors. And there are so many ocular and systemic conditions that predispose to the neovascular glaucoma, like I have shown in the slide, but I'm not gonna describe everything. But most of them all, diabetic retinopathy and ischemic CRVO each plays around 33% of the cases, and ocular ischemic syndrome plays 13% of the cases development of the neovascularization. And there are few stages like the pre-rubeotic, rubeotic, secondary open angle, and secondary angle closure. So if a patient with neovascularization develops glaucoma, that is quite difficult to manage medically. And in that case, we have to go for the surgical management to control the intraocular pressure. And as I've said earlier, there are so many medical and ocular conditions that causes the neovascularization. So we have to deal it in a multidisciplinary approach. So here is the first case of mine, who is a 47 years female, and she was a diagnosed case of primary angle closure glaucoma and had a history of trabeculectomy and cataract surgery in the left eye. And she came to me with the history of blurry vision, acute eye pain, watering, photophobia, and redness in the right eye. And when I examined her, her visual acuity was 660 in the right eye and 618 in the left eye. And she was on highest anti-glaucoma medication in the right eye. Despite having the highest anti-glaucoma medication, her intraocular pressure was 47 millimeter mercury. And in the left eye, it was 12 millimeter mercury without any anti-glaucoma medication. So if you see this anterior segment image of this patient, you can see the extensive rubeosis iritis as well as the ectropy on UV and grade 1 nuclear sclerosis. And if you see the angle, there is a fine new vessels over the anterior chamber angle, but the angle was open. And if you dilate the patient and see the fundus, you can see there is a supratemporal VRVO as well as the pale disc and the sclerosed vessel. So when I go for the visual field, you can see the advanced glaucomatous damage in the visual field as well as the nerve fiber there. And there was also cystoid macular edema. And for this purpose, as I've mentioned earlier, you have to deal this patient in a multidisciplinary manner. So I referred this patient to my VR colleagues, and they took care of the macular edema as well as the supratemporal VRVO with the lasers and antivascular endothelial growth factor injection. And later they referred back this patient. Despite having the highest anti-glaucoma medication, I had to go for this patient with augmented trabeculectomy along with the cataract surgery. So if you look at the literature, why did I choose the augmented trabeculectomy along with the cataract surgery in this patient. It shows that the traditional trabeculectomy has the high failure rate, but if we augment it with the mitomycin C or the 5-fluorouracil, then the success rate rises from 62.6% to the 81% in 1 year. Though it shows that it reduces up to 51% at the 5 years interval, but you can increase the success rate by using the preoperative anti-VEGF. So I had to go for the augmented trabeculectomy with cataract extraction in this patient. Right now, I put the 0.02% MMC in the subconch, then do the fornix-based peritomy. And secure the bleeding point with minimum cautery, and triangular scleral flap was created. You have to be very cautious because you have to make it in a single plan. So there won't be any rag margin. And then the cataract surgery was done in an usual manner. Actually, I didn't change my position. I used the separate port for the trabeculectomy and the cataract surgery. So the cataract was removed. And the cortical matter was also removed thoroughly. And later on, single-piece intraocular lens was implanted within the capsular bag. And after that, I had to do the sclerostomy with Kelly sponge forceps and the surgical PI as well. And later, the triangular flap was closed with a single suture at the apex. And the thorough visco wash was given. And later reform the anterior chamber and check for any leakage and close the conch with atovicryl in a watertight manner. Then you can finish the surgery with intracameral antibiotic as well as the subconch steroid antibiotic combination. So if you look at the follow-up of this patient, this is the first postoperative image of this patient, where patient had the uncorrected visual acuity of 636 with intraocular pressure of 14 millimeter of mercury without any anti-glaucoma medication. And later on 7th POD, her visual acuity improved as well as the intraocular pressure within the normal range with good diffuse functioning blade. Up to the 13th, from the 13th postoperative day to the 4th month, she was maintaining the good visual acuity with intraocular pressure within the low teen. And if you see the bleb, it is quite diffusely elevated, moderately vascularized, and well functioning. And in the fundus, you can see the laser mark over there. And visual field, though it looks a bit deteriorated, right, most probably due to the laser it was due to the laser. So the next case is 68 years old male, who is a diagnosed case of hypertension. He had a history of cataract surgery followed by the yak capsulotomy in the right eye. This patient also came to me with a history of blurry vision, acute pain, watering, photophobia, and redness. And his uncorrected visual acuity was 618 in the right eye and 660 in the left eye. And he was on highest anti-glaucoma medication in the left eye. Despite having it, it was 54 millimeter mercury in the left eye, but the IOP was normal in the right eye. It was around 16 millimeter mercury. So if you look at the anterior segment image, you can see there is a neovascularization of the iris around the pupil and the nuclear sclerosis grade 1 cataract. But if you see the angle, it is totally closed, and there was a peripheral anterior synechiae as well. And there is an extensive glaucomatous optic disc damage as well as the superior-temporal VRVO. And there was an advanced glaucomatous field defect as well as the nerve fiber layer defect and the cystoid macular edema due to the branch retinal vein occlusion. So as I've mentioned earlier, I had to send this patient to my VR colleague to deal with the superior-temporal VRVO and the cystoid macular edema, and they treated the patient with anti-VEGF as well as the laser. So despite having the almost same feature like the previous one, why I had to go for the glaucoma drainage device along with the cataract surgery in this patient? As my previous presenter already mentioned about the TVT study, it showed that the glaucoma, uncontrolled glaucoma with barbelled glaucoma implant or trabeculectomy shows that the 70% tube group shows the success rate at the 5 years than the trabeculectomy group, which is around 53%. So I had to go for the glaucoma drainage device along with the cataract surgery in this patient. And first of all, I had to give a traction suture to expose my operative field. Then the peritomy was done. It's not that small incision like the previous presenter showed. And I had to secure the muscles, that is the lateral rectus muscle as well as the superior rectus. Then I had to ligate the tube and check whether it is, then the titrate it, whether I had to put another suture or not. Then place the fluid plate within the muscle belly and secured it within the sclera with tenos seal. Then I did the cataract surgery in an usual manner. But you have to be very careful because there's an extensive neovascularization over the iris. So any unwanted, inadvertent touch will lead to the hemorrhage or hyphema in later on. And now I'm not going to put the scleral patch graft. That's why I took the scleral flap. Then enter into the anterior chamber and put the tube within the sulcus actually. That is behind the iris. And secure the tube within the sclera with 10-0 nylon. So does the scleral flap. And later close the conch in a watertight manner. So you have to be very careful while closing the conch because it should be watertight and there shouldn't be any leakage later on. And later you have to thoroughly clear the visco as well as the hyphema and check for any leakage after that. And you can close the surgery later on with putting the subconch antibiotic steroid combination injection. So what was the post-op and follow-up of this patient? If you look at the first post-operative day, you can see the visual acuity was counting finger 1 meter with intraocular pressure of 20 millimeter of mercury with single anti-glaucoma medication, but there was a hyphema. It was around 1.5 millimeter, and you can see the tube within the sulcus. On 7th post-operative day, his visual acuity was improved to 660 and IOP was within the mid-teen and with single anti-glaucoma medication, and there wasn't any hyphema that time. And from the 3rd post-operative day up to the 6th month, patient was maintaining good vision with good intraocular pressure with only single anti-glaucoma medication. And this is the post-op visual field as well as the post-op OCT of the macula. So my last case is the cyclophotocoagulation. So it was a case of 71 years male who was a diagnosed case of advanced diabetic eye disease. And he had a history of first planar vitrectomy as well as the cataract surgery in the left eye. And this patient this time came with a painful blind eye. And when I examined, his visual acuity was no perception of light in the right eye and 624 in the left eye. And he was in already highest anti-glaucoma medication and IOP was 54 millimeter mercury in the right eye. So if you see the anterior segment image, you can see there is an extensive neovascularization as well as the cataract. But whenever you see the fundus, there was extensive fibrobascular proliferation, fractional retinal detachment, and you can't appreciate whether there is any optic disc or the macula. So despite all of these things, I had to go for the cyclophotocoagulation in this patient. So what does the cyclophotocoagulation actually does? It does destroy the ciliary body and thus ultimately reduce the aqueous production. And it is particularly useful for the patient with poor visual outcome like this patient and refractory IOP elevation. The benefit of this thing is it is titrable and it can be repeatable. And recently, there some studies shows that it can be applied as a primary therapy as well. And you can put it in a 360-degree or in a sectoral manner, depending on the target IOP you want to achieve. And you can apply around 20 to 25 burns per application. So this is the procedure where you can apply it. It's around 1 to 1.5 millimeter below the limbus. You can just set the set the power you want, and then you can just press the button. And later on, you can, if you see the patient after 2 months, you can see that the IOP was lower to 21 millimeter mercury with single anti-glaucoma medication, and it was maintained good IOP with after the 2 months, and later on after the 4 months, it showed the 16 millimeter mercury, and you can appreciate the scleral marks of the laser, and the patient develops already the cataract also matured in that cases. So regarding my presentation, what are the key learning points? So all neovascular glaucoma doesn't mean the end of sight, and you have to deal very aggressively which causes the neovascularization. And that's why you have to deal this patient in a multidisciplinary approach. And another thing is primary angle closure glaucoma is one of the important causes in our country that causes the neovascularization and later on the neovascular glaucoma. So, and lastly, we have to improve the quality of life of this patient, not just to reduce the intraocular pressure. And that's all. Thank you.
Thank you, doctor, so much. Now I request Dr. Professor Zakia Sultana, madam, please give your valuable opinion regarding this presentation. Madam.
Thank you. Can you hear me?
Yes.
I have lots of problems before joining over here. Anyway, at last I joined you. Thank you, Ashfia. Thank you, Dr. Ashraf, for selecting me as a panelist to give opinion regarding Dr. Iftekher Iqbal's presentation. It is a very enjoyable presentation. Dr. Iqbal, thank you so much for showing the videos and different types of treatment.
Thank you.
Actually, what I think, the neovascular glaucoma is a challenging, really challenging to diagnose it and challenging to treat it. While going to diagnose it, we have to see meticulously the iris, meticulously see the angle, whether there is any neovascularization. Especially, I think in those cases which are connectable with which can cause this neovascularization, iris neovascularization. Okay. Then now next comes the treatment. We have to treat two things. We have to treat the glaucoma. We have to give prophylactic treatment. Regarding the treatment, in case of medical treatment, we have to remember that in giving the anti-glaucoma medications, we don't want to give the anticholinergic drugs, especially in case of inflammatory glaucoma, and PG analog, we can avoid it in case of PAS. So, but we must not forget about cycloplegic and steroid while treating medical treatment. Now, regarding the surgical treatment, you have shown me augmented trabeculectomy and using valve implant and also cyclodestructive procedure. The thing is that in filtration surgery, in some of study, it has been shown that 5FU is more effective rather than MMC. And secondly, the filtration surgery, we're using the glaucoma drainage device, the effectivity gradually declines. And whenever there is nothing to do and the media is hazy, we can go for cyclodestructive procedure. So it needs a randomized clinical trial that what is the most effective treatment in these three cases, these three type of procedure, like filtration with MMC and using the bulb. Dr. Ashraf, one thing I want to know that in which type of operation you are getting more effectivity?
Now, madam, it actually depends on the patient's condition. If the patient had the angle is open, and if you can control the causes of the neovascularization, like this patient, they have the BRVO, and the cystoid macular edema. If you aggressively treat those things, then the neovascularization will regress, and in that case, trabeculectomy will do the job. But most of the time, if you see the angle is closed and there is a total or extensive peripheral anterior synechiae and the neovascularization, in that case, it's quite sure that the trabeculectomy will fail. So in that case, I will go for the glaucoma drainage devices. And the last one is the cyclodestructive procedure. If the patient doesn't have the vision or poor vision, then I'll go for the cyclodestructive procedure in that case.
Okay, so we must be careful about the bleeding, no? It can
Yes.
cause scarring and other things, and it's very difficult to manage once the bleeding starts, no?
Yes.
And we should not forget about prophylactic treatment like PRP and anti-VEGF. So you are absolutely right that it is a joint venture between the retina specialist and the glaucoma specialist. So we must keep in mind regarding this and should not compromise. Only giving glaucoma treatment and send the patient without giving any prophylactic treatment, it shouldn't be, no. So again, thanks to you. Thanks a lot for your nice presentation along with videos. Hope that you will be more successful in treating this type of surgery. Thank you again.
Thank you, madam.
Thank you, madam, for a valuable opinion. Thank you, Dr. Iqbal. Now I request